Hello, and welcome to the Radiology Economics and Policy Learning Electronic Toolkit, REPLETE. This program was made possible through a GE Healthcare RSNA Education Scholar Grant from the RSNA Research and Education Foundation. I'm Rich Duzak from Emory University, and this session is another part of the Follow the Money series of REPLETE entitled Managing Costs Responsibly. This module is targeted to Level 2 of the Diagnostic Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. Milestones levels differ for the various ACGME-approved radiology training programs, and so if you are in a program other than diagnostic radiology, please reference the REPLETE resource webpage for mapping this module to the correct level for your individual program. The learning objectives for this module are as follows: to describe the fundamental components of a radiology practice's income statement, to understand the interplay between revenue and various expenses within an organization's overall financial well-being, and to identify opportunities to reduce unnecessary costs and maximize the impact of existing and anticipated human and capital resource expenditures. Here are some additional resources listed alphabetically by author for those who would like to learn more about the topics in this module. I have no expectations that this module will make you an accountant or a financial wizard or even a savvy consumer of income statements or other organizational financial reports. Instead, my goal is to provide you some big picture perspectives to hopefully demystify this topic, because I know it's something about which few of us get formally educated. Throughout REPLETE, most of the focus has been on evolving physician payment systems and therefore revenue. But the revenue your practice generates gets rapidly chewed away by a variety of expenses. You see types listed here in this cascading graphical depiction of how a lot of revenue can turn into just a tiny bit of leftover net income after you pay all your bills and your taxes and account for capital depreciation. I'm not going to get into those accountancy weeds, but instead I plan to provide some broader and strategic perspectives about ways you can help manage your practice's bottom line. The phrase bottom line, by the way, comes from this equation: revenue minus expenses. What's left over is your profit or your loss. But either way, it's the bottom line in this equation, and hence the origin of that term. And so while we focused quite a bit, and will continue to do so, on payment systems and coding and billing throughout REPLETE, the revenue side of your income statement, in this module, we're going to step back and look at expenses at a high level, not from the perspective of how to account for each and every line item uniquely in a financial ledger, but rather by providing broader context about how you can think about your practice's expenses in a way that will help you manage them in a strategic manner. You may remember in an earlier module we talked about costs more broadly and really focused on costs from the perspective of the patient, that is, the expenses they paid out of pocket. And we talked about costs as well from the perspective of the payer. Remember, insurance companies and other third parties pay most dollars of most healthcare bills. Together, these are the expenses borne by society for healthcare, either directly from patients or from the rest of society more broadly, whether it be patients through their annual premiums, their employers as an employee benefit, or in the case of Medicare or Medicaid from our government. You'll remember that I told you that every time you hear the word cost, you should think of it as an expense to one party or another. Always ask yourself this question: costs to whom? And so in this module, we're going to look at the expenses incurred by your practice as the cost of doing business. Those are your expenses, some of which you can pass on to patients and/or insurers, and others which you cannot. You see listed here the types of variable and fixed costs and expenses we outlined briefly in that prior module. We'll drill down on those costs a bit more in this one. Again, your expenses, the second line in that dummy-down bottom line equation I shared with you a moment ago, are your costs of doing business. And in a very simplified way, these can be placed into three different buckets: people, capital, and supplies. One of the most costly buckets for most businesses, and this certainly holds true in healthcare, is our people. And in radiology practices, these consist of three large groups: our physicians, our non-physician clinical staff, most commonly our technologists and our nurses, and our administrative staff, whether they be practice managers, schedulers, coders and billers, or the many, many other people who play critical roles behind the scenes, helping us run the businesses that allow us to serve our patients. Capital is another big bucket for radiologists. We're a high-tech specialty, and so our practices are very capital intensive. We need big buildings to house our equipment, and that often involves modifying those buildings to shield them from radiation or magnetic fields. We need scanners and other imaging equipment, and many of those pieces of equipment in our department, just like yours, start at about $1 million or more. And don't forget, too, that we need expensive computers and servers and software systems to allow us to practice efficiently and robustly in our fast-paced digital world. And finally, we need a lot of supplies. Contrast is commonly used in most of our diagnostic and our interventional practices, and the devices we use in our interventional suites are all quite expensive. And don't forget that the administrative side of our practice chews up supplies as well, whether they be batteries for our pagers, toner for our laser printers, or light bulbs so that you're not working in the dark. Collectively, this stuff is all quite expensive. But one thing I've seen quite a bit in some of the practices I've visited is that there are not uncommonly middle-level managers who worry only about their own little pieces of the budgets, and therefore wind up being penny-wise and pound-foolish from the perspective of the entire enterprise. One practice I helped as a consultant in the past, for example, was regularly paying their very expensive interventional radiology technologists and nurses overtime because they couldn't get their inpatients down on time during the workday and had to work into the evenings. The root cause of this was a hospital transporter shortage, but transporter hiring was the responsibility of another non-radiology vice president who was only worried about making his budget look good. As you can imagine, the solution there needed to get kicked up to a higher level in the C-suite so that the institution's broader incentives were aligned with the bonus compensation structure of that vice president, who stood in the way of making the radiology practice more efficient, financially sustainable, and, of course, patient-friendly. As radiologists, we are often involved in the care continuum throughout our departments and our health systems more broadly. And as such, we are often in the position to see this type of dysfunctional fragmentation from a patient care and workflow perspective, and in that way are in great positions to be able to provide our hospital administrative partners valuable insight and leadership to make our institutions even better. So with that broader perspective in mind, let's spend a few minutes now talking about each of these buckets individually. In any healthcare organization, people are your most valuable assets. They're the well-educated and highly trained knowledge workers who allow us to deliver the best care possible. And ideally, they're the empathetic and caring workers who allow us to deliver our services in as patient-friendly a manner as possible. But as everyone asks more and more of these individuals, burnout is endemic. And so if your competitors, other hospitals, or imaging centers in town offer your people a better lifestyle, or better pay, or a better culture, recognize that your people will think seriously about jumping ship, which obviously could create for you manpower hardships and substantial workflow challenges. And hiring isn't easy, nor is it cheap, nor quick. And so it's better to retain good people than to have to recruit their replacements. Remember, for physicians at least, scut work is not only a big dissatisfier to them, but also a big cost center for you, and an opportunity to help improve your bottom line. Let's spend a few minutes and talk about just that. Ideally, for both professional satisfaction as well as cost management, you want your doctors practicing at the tops of their licenses, meaning not doing things that one doesn't need an MD degree to do. Answering phones, sending faxes, and looking up pager numbers is not a good use of physician time. And that's why many practices, including our own here at Emory, have hired a team of reading room coordinators who serve as our administrative partners in care delivery. You see a figure here by Dr. Andy Rosenkrantz at NYU, illustrating how their radiologists embraced reading room coordinators. Once these individuals were on board and ramped up, their physicians increasingly offloaded rote administrative work to them so that they could better focus on their work as radiologists. On the clinical side of things, you can use non-physician providers to similarly keep your radiologists working at the tops of their licenses. Dr. Matt Hawkins from our group at Emory has written a really nice review series on this topic in the JACR, something that we'll talk about more in levels 4 and 5 of Replete. But in short, remember that there are some very talented, non-physician providers who can do a really good job in a variety of things. They can help you triage cases and guide your referring physicians in getting the right tests at the right time for their patients. They can help patients get into your interventional radiology clinic and help with your IR inpatient rounds. And they can do a variety of less complex procedures, such as paracenteses and thoracenteses, that probably on a routine basis do not need a physician to do. These are all services where evidence is mounting that these individuals, who cost your practice a lot less than radiologists, can perform quite capably as long as they are appropriately trained and appropriately supervised. But using them means thinking a bit outside of the box with regard to how you engineer your workflow. Let's talk about a hypothetical practice of 8 radiologists. This small group had no ancillary support, and so the radiologists themselves had to answer every ringing phone, look up every referring physician's pager number, and call IT themselves every time they needed, for example, a new mouse battery. They needed to perform themselves every H&P and perform every PICC line and paracentesis and thoracentesis procedures, even if they were the most straightforward and basic ones. Let's say, for example, that about 25% of those radiologists' time was spent doing things that a reading room coordinator or a non-physician clinical provider could do. And so think about what would happen if they hired 2 additional people to address that work being done by their physicians. And I don't mean hiring 2 more doctors. I mean hiring 1 reading room coordinator and 1 non-physician provider. Suddenly, they could recoup the work of 2 additional doctors, but at a salary of 2 professionals that you don't need to pay as much. My point here is that when you look at a spreadsheet alone, you might say that you're taking on new costs by doing something innovative like this. And indeed you are. But assuming the work is there or that you can grow your work, you're ultimately saving money. And so what we need to be all thinking about is working smarter and not necessarily working harder. If all you're doing, though, is sitting in a reading room and dictating studies and not thinking about your practice more broadly, then this kind of out-of-the-box thinking never happens. These are real leadership opportunities to enhance your practice's bottom line and improve morale and patient care all the while. Like people, capital is a second big bucket when it comes to expenses. When we talk about capital, we're talking about really big ticket items, and for radiology departments, this typically means things like new CT scanners and MR scanners and interventional radiology suites, as well as new PACS systems. Most of our departments see a flurry of requests for these type of big ticket items after the RSNA annual meeting each year, when vendors from all across the world are showing off their fanciest and newest innovations. So it's not uncommon for radiologists to come back from that meeting or others and say, I want this or I want that. The real question, though, that our practice and hospital leaders should ask is whether they need those things now or at all. And if they do need them, what are their plans to use them to their fullest? You don't want to spend $1 million on a piece of equipment that sits idle most of the day. And additionally, since none of our health systems has infinite resources, we need to remember that buying 1 new shiny scanner means that there's another one that you won't be able to buy that year or maybe even next. These decisions, then, requiring weighing pros and cons and various alternatives. The concept unique to capital, aside from the fact that it's so darn expensive, is that it depreciates. Everyone talks about a new car depreciating as soon as you drive it off the lot. The second you pull out of the parking space, they say, the price that you get to sell it back to that dealer drops quite a bit. That's the nature of high-tech capital. The same thing that applies to cars applies to CT scanners and MR scanners and interventional radiology suites. These are very expensive assets, and they all lose value very quickly. And so the challenge for all of us as stewards of finite resources is to make sure that you're using that expensive equipment most judiciously. One way to address this is to make sure that you're using your capital to its fullest. Let's take the example, and this is common in a lot of radiology departments across the country, of a CT scanner in the outpatient area that only runs from 8 to 5 on Monday through Friday. In that not-so-hypothetical practice that I highlight here, that $1 million machine is running only 189 hours a month. That means that more hours than not, it's not generating any revenue for your practice. All it's doing is depreciating. But what if you thought a little bit outside of the box and open your outpatient facility on weekends, when, by the way, it's actually more convenient for many working patients to come to your practice, then you'd be running that scanner not just 189 hours a month, but instead 279 hours a month. That's a 48% increase in capacity and basically a 50% boost in potential revenue. Yes, you need to pay technologists and aides and clerks to work those extra 90 hours, but you don't have to buy another scanner, and so the cost per scan goes down quite a bit. What that means is that your hospital can get an additional 50% in revenue for a much lower incremental increase in expenses and expand access to a lot more patients. Let's take that concept one step further. And what if just beyond adding weekend hours, you also expanded hours into the evenings? Remember, lots of people miss out on income when they miss out on their jobs, and they would be glad to come in after work. Most patients would prefer to come to your center when it's convenient for them, not just when it's convenient for you. So staying open until 8 p.m., that's just an additional 3 hours a day, expands your runtime now to 372 hours a month, or 98% above your baseline. Doubling your capacity this way, you essentially get a second scanner for free. But it all requires being willing to think outside of the 8 to 5, Monday to Friday box and sell that concept back to your partners and your administrative partners as well. One thing to remember, whether you're making a capital purchase or buying supplies, which we'll talk about in a moment, is to comparison shop. Many institutions have, quote, preferred partnerships with various vendors and haven't shopped those stagnant relationships in many years. Vendors, as a result, sometimes become complacent, taking your business for granted, knowing that you'll pay whatever price they ask. Shopping around helps you get the best prices on both capital and supplies. Think about your own personal shopping habits. Many of us now use Amazon or other online services. We regularly comparison shop for prices in our personal lives and need to make sure that we do so in our professional lives as well. Many of us also save a lot of money by buying things bulk at Costco or Sam's or whatever warehouse club you might like. That personal habit is one that we should think about at work as well when we buy supplies. And radiology departments sure go through a lot of supplies. It's easy when you're going through your hospital budget process to focus on the big dollar items, the CT scanner or the MR scanner or the shiny new interventional radiology suite, all the while neglecting lots of little things. A couple dollars here for contrast, $10 here for a PICC line, $50 here for a stent. It all goes under the radar. One reason it does is that supplies are often purchased in small amounts, without any single dollar amount enough to invoke scrutiny. This happens pretty commonly. I may like this biopsy needle and ask my techs to buy 10 of them. You may like that one and ask them to buy 20. All the while, nobody notices that we're paying top dollar. That variation is the enemy of economy. Think about this practice where a whole lot of docs cover the CT and ultrasound biopsy slot. All 7 of them have their own pet needles, even though they're all essentially the same devices, just made by different vendors. That means that your hospital is probably paying top dollar for all of those. And so the system opportunity here is to standardize whenever possible, trying to identify equally effective alternative products where you can buy bulk and save money. Forward-thinking practices do this for devices, whether needles or stents or ports or catheters. And they do it for contrast as well. It requires a bit of leadership and consensus building to standardize protocols and care pathways, but it also results in considerable cost savings as well. And minimizing those expenses, just like maximizing revenue, as we've talked about in other modules, translates into a better bottom line. Now, you may say, I'm a doctor and I care about patients. This is all more than about the money. And I agree, it absolutely is. But in order to provide the best care and advance the specialty, you need to be able to recruit and retain the best staff, offer state-of-the-art care, expand patient access. And if you're in a teaching institution, research and innovate, teach and train. And all of us need to stay financially solvent. And so even if you're working in a non-for-profit environment, remember the old adage, no margin, no mission. That is, if you don't have a positive bottom line, then you won't be able to carry out your mission. So in summary, revenue is an important contributor to your practices and your department's bottom line, but it is only one part of that. Healthcare enterprises are only profitable if they manage both revenue and expenses. Standardization initiatives and systems thinking will optimize the ability of radiology enterprises to sustainably carry out their missions. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the RIPLEAD initiative and additional resources are available on the RSNA's website. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in RIPLEAD.